Fever of unknown origin is a classic and challenging diagnostic puzzle in internal medicine. It is formally defined by specific criteria. First, a documented fever greater than 38.3 degrees Celsius or 101 degrees Fahrenheit on multiple occasions. Second, a duration of illness exceeding 3 weeks. And third, no diagnosis established after 1 week of intensive inpatient investigation or after 3 comprehensive outpatient visits. Modern classifications also include specific types like hospital-acquired fever of unknown origin, fever of unknown origin in patients with low white blood cell counts, and human immunodeficiency virus-associated fever of unknown origin. The causes of fever of unknown origin are traditionally grouped into 4 major categories. The most common category, accounting for 25 to 35% of cases, is infections. This includes hidden abscesses in the abdomen or pelvis, bacterial infection of the heart valves, tuberculosis, complicated urinary tract infections, and diseases transmitted from animals. The second category is non-infectious inflammatory diseases, responsible for 20 to 30% of cases. This includes autoimmune and autoinflammatory conditions. Giant cell arteritis in patients over 50 years of age is a classic cannot-miss cause. Also consider adult-onset Still's disease, granulomatous diseases like sarcoidosis, and various blood vessel inflammations. The third category is malignancies, accounting for 15 to 20%. Lymphomas are the most common culprits. Others include kidney cancer, liver cancer, a rare heart tumor called atrial myxoma, and cancer that has spread from its original site. The fourth category is miscellaneous causes, making up 15 to 20%. This includes fever caused by medications, self-induced fever, hereditary periodic fever syndromes, blood clot diseases like pulmonary embolism, and endocrine disorders such as an overactive thyroid. Finally, in approximately 5 to 15% of cases, the fever remains undiagnosed, often resolving on its own. The diagnostic journey begins with an exhaustive, clue-based history. Meticulously document the fever pattern. Certain patterns can point toward specific infections or cancers. A detailed epidemiologic and exposure history is non-negotiable. Ask about recent or remote travel, occupational exposures, contact with animals, sexual history, intravenous drug use, and any recent medical procedures or surgeries. Elicit all constitutional symptoms. Significant weight loss, drenching night sweats, profound fatigue, joint pains, and muscle pains. Scrutinize the history for any localizing symptoms no matter how subtle. A mild but persistent headache, a temporary rash, or pain in a single joint can be the critical clue. Finally, perform a complete medication review, including all prescription drugs, over-the-counter medications, and herbal supplements. Remember, fever often presents with a rash and a relative bradycardia, where the heart rate is slower than expected for the degree of fever. The physical examination is equally crucial and must be repeated over time. Monitor daily vital signs closely. Note the presence or absence of a pulse temperature dissociation, also called relative bradycardia, which is seen in typhoid fever, brucellosis, drug fever, and some lymphomas. Perform a comprehensive head-to-toe examination during each evaluation, with special attention to lymph nodes, the skin for any rash or nodule, the eyes for redness or inflammation, careful palpation of the temporal arteries in older adults, listening to the heart for new murmurs. Abdominal, examination for organ enlargement or tenderness, and a joint examination. Do not omit examination of the back of the eye with an ophthalmoscope to look for signs of widespread infection. The initial diagnostic workup involves a standard first-line set of tests. Basic laboratory tests include a complete blood count with manual review to look for a high white blood cell count, immature cells, atypical lymphocytes, or eosinophilia. A comprehensive metabolic panel assesses liver enzymes, alkaline phosphatase, and kidney function. Inflammatory markers, specifically the erythrocyte sedimentation rate and C-reactive protein, are essential. Obtain at least 3 sets of blood cultures from different sites, ideally drawn during fever spikes. Always include a urinalysis and urine culture. A chest X-ray is mandatory. For imaging, a computed tomography scan of the chest, abdomen, and pelvis is the modern cornerstone of the fever of unknown origin workup, excellent for identifying hidden abscesses, swollen lymph nodes, or masses. If the initial workup is unrevealing, proceed to second-line and specialized investigations. Order advanced blood tests based on clues from the history and exam. This may include human immunodeficiency virus testing, viral antibody tests, tuberculosis testing with an interferon gamma release assay, fungal antibody tests, and autoimmune panels. Perform an ultrasound of the heart. A transesophageal echocardiogram is better than a standard echocardiogram for detecting small growths on heart valves in cases of suspected endocarditis. Consider nuclear medicine imaging. Fluorodeoxyglucose. Positron. Emission. Tomography, combined with computed tomography, is highly sensitive for identifying areas of inflammation or cancer and can guide where to biopsy. Other scans using gallium or labeled white blood cells are alternative options. Ultimately, taking a sample of tissue or biopsy is often the definitive diagnostic step. Target the most abnormal tissue accessible, such as an enlarged lymph node, the liver, bone marrow, or, in the appropriate patient, the temporal artery. Management follows specific principles. First, avoid giving antibiotics without a clear target whenever possible. They can obscure culture results and delay the true diagnosis. Exception is made for critically ill patients, or when there is a strong specific clinical suspicion for a particular infection. Use fever-reducing medications judiciously for symptom relief, understanding they may mask the natural fever pattern. Therapeutic trials should be based on a strong suspicion, not given blindly. Examples include a trial of tuberculosis medication for suspected tuberculosis, a trial of corticosteroids for suspected giant cell arteritis, but only after performing a temporal artery biopsy, or a trial of non-steroidal anti-inflammatory drugs for suspected adult-onset Still's disease. Finally, commit to diligent monitoring and follow-up. Many causes of fever of unknown origin become clear over time. Reevaluate the history and repeat the physical examination at regular intervals. In summary, approaching fever of unknown origin requires a systematic, step-by-step, and patient strategy. The history and physical exam, especially when repeated over time, remain your most valuable diagnostic tools. Modern imaging, particularly computed tomography and positron emission tomography scanning, has revolutionized the diagnostic pathway. When the diagnosis remains elusive, remember to consider a temporal artery biopsy in elderly patients and pursue a tissue biopsy from the most accessible abnormal site to obtain a definitive answer. Thank you for watching. Don't forget to like, share, and subscribe. See you in the next one.